Hello, everyone, and welcome to NCSL's webinar, Value-Based Care in Oral Health, Connecting the Dots. My name is Eric Skinner, and I will be moderating the webinar today. I am a policy associate with the National Conference of State Legislatures. Today's webinar is a platform for information exchange and engagement. Over the next 60 minutes, we encourage participation through our chat box, so feel free to type your questions and answer any questions in the chat box, which is in the lower left-hand corner of your screen. To begin building some comfortability with the chat function and also to learn who is on the line, I invite you all to type in the state from which you are calling in now. I want to briefly mention the resources. Above the presentation on your screen, you will see a couple tabs with one of them labeled Resources. Here you can find and download a PDF version of the PowerPoints as well as some other handouts. Another tab is labeled Speaker, where you can find the bio of today's speakers. You can access these tabs at any time during the presentation. Today's webinar is being recorded and will be available on NCSL's website within 2 weeks. And one note about the resources, you will see NCSL resources in one tab, and then resources from our presenters that are their own creations separately. For those of you who are not as familiar, the National Conference of State Legislatures is the bipartisan organization that serves the legislators and legislative staff of the states, commonwealths, and territories. NCSL provides research, technical assistance, and opportunities for policymakers to exchange ideas on the most pressing state issues, and it is an effective and respective advocate for the interests of the states in the American federal system. The conference operates from offices in Denver, Colorado, and Washington, D.C. NCSL does not advocate for specific policies, nor do we take positions on state issues. This webinar is a platform for information exchange. We hope that this webinar will help answer your questions. Before we get started, I'll walk through this brief Before we get started, I'll walk through this brief overview, and after a bit more housekeeping and introducing the topic, I will pass it off to Mary Foley. Mary is the Executive Director of the Medicaid, Medicare, and CHIP Services Dental Association, or MSDA. Mary will describe value-based care and what it looks like in the oral health system. She will also present state opportunities for innovation. Mary will take a brief pause for questions, and then I'll step in and introduce our two legislative respondents, Representative Singer from Colorado and Representative Ellison from the state of Utah. They will describe their experiences enacting oral health legislation that touches on the components of value-based care and purchasing, and we will have another opportunity for questions, and then we will wrap up the webinar. With this slide, I just want to talk about why we thought this webinar was necessary today. If you work in the health system or work on health issues that involve the health system, you know that the terms value-based care or value-based purchasing are unavoidable. Defining value can also be difficult. Most would agree that value-based care or purchasing involves initiatives that address some aspect or both cost and quality of care. But without proper measurement and data tools in place, there may not be a way to know if a program is promoting value or if it is simply a prevention program, quality improvement program, etc. Whatever the challenges are, value-based policy is a means and not an end. It is valuable to the extent that it allows policymakers to align parts of the health system with concepts of prevention, cost containment, and improved health. Like many health issues, measurement is critical. And so with that nebulous introduction, Mary Foley has the challenging task of moving into the tangible and describing what value-based care and purchasing looks like in the oral health system. And I will now hand it over to Mary Foley.
Thanks, Eric. So good afternoon. I'd like to begin today by thanking my colleagues at NCSL for inviting me to present on value-based purchasing and care. It's my pleasure to be here with Representative Singer from Colorado and Representative Ellison from Utah. As noted, I am the Executive Director of the Medicaid, Medicare CHIP Services Dental Association, or MSDA. For those of you who have never heard of MSDA, we are the national membership organization representing the state administrators and policymakers, which are the directors, the managers, and the staff of state Medicaid and CHIP dental programs. But in recent years, as the Medicaid environment has changed and states have moved to contracting with dental vendors and other vendors to administer their programs, we have expanded our membership to include state Medicaid vendors, which are those kinds of corporations that contract and subcontract with Medicaid programs to administer and deliver health and oral health care services to Medicaid and CHIP beneficiaries. Our membership also includes those individuals and groups, such as dental and medical providers, educators and researchers, and others who have an interest in Medicaid, Medicare, and CHIP dental programs and their beneficiaries. Our mission is to improve Medicaid, Medicare, and CHIP oral health programs by collaborating with key stakeholders, sharing resources, and disseminating innovative strategies. We provide leadership in the development of sound dental policy. We support beneficiaries. We stimulate discussion among all the different Medicaid stakeholders. We promote integration of oral health and primary care. And most of all, we promote quality and improved health care and lowered costs for Medicaid, Medicare, and CHIP programs. Each year, MSDA surveys the state Medicaid dental program administrators to gain input from them on topics such as how they administer their programs, whether they are fee-for-service or have moved to a managed care or an accountable care model. We ask them if they're carved in or if they have carve-out models, and we ask them if they're single payer or if they have multiple vendor contracts. These are just a short example of some of the kinds of things we ask them. And then we publish this detailed information in an online profile called the MSDA National Profile of State Medicaid and CHIP Dental Programs. As part of this exchange of information, we ask states, what do you need to improve your programs? We ask them, what are you looking for from stakeholders? In the past year, we've worked closely with Dr. Mark Doherty from the DentaQuest Partnership for Oral Health Advancement to learn more about value-based care and value-based purchasing. At the end of the day, we've come to understand more than ever that this new notion of value-based, simply stated, translates into administering a program that meets the needs of the states, the providers, the vendors, and most importantly, the enrollees, or what will ultimately be the beneficiaries. Today, I plan to share with you what we've learned from the states in an effort to help you and others gain insight on how to better support the state Medicaid programs in their work. So what do states tell us they need? What are they looking for? What do they want? Generally speaking, they tell us they're looking for improved healthcare services and administrative processes. They're looking for improved health outcomes. They need to deliver these services with lower costs that ultimately look at a decreased per member per month, a decreased PMPM. They need a broader provider network to make sure that they're meeting the demands of all the beneficiaries in their network. They're looking for a broader benefit package. And all of this means increased capacity, which yields increased access and ultimately an increased use of services. They're looking for decrease in their disparities among the populations that they serve, which also means increased equity in service delivery. That's new. They're looking for increase in preventive services, and they're looking for models which couple performance and cost measures with value-based programming. They need measures that demonstrate improvement across all quality domains. They need a program model that's cost-effective, and in order to be effective and achieve this, They need metrics and measures that demonstrate that the program model works. When we talk about the domains that I just mentioned, those are the areas or the categories of a program that contribute to systems healthcare delivery. So here you see from the Agency for Healthcare Research and Quality on the right-hand side, you can see these different domains, okay? The first domain, okay, or the first section, which is clinical quality measures, talks about process, access, outcomes, structure, and patient experience. States need measures, not just one measure, but states need measures in each one of these categories, because when they have a measure in each category, they can really zero in on how they can improve their programs. The same is true for outcomes. They need to understand how they are administering their programs in a way and what those outcomes are and if those outcomes are effective. And finally, and very importantly, they need to understand the efficiency of their program. And that obviously goes back to cost. So let's dive into this a little bit deeper and see what else states have reported to us that they need and some of the potential strategies that could address these needs. So let's begin with preventive services. All states have reported that they need to be able to increase the delivery of preventive services across their population groups. They need to demonstrate reduced disease incidence, reduce treatment costs, and improve the utilization of preventive dental services to the youngest cohort of children, that is those children ages 0 to 3, and be able to measure those outcomes using quality indicators as a result. So what can we do? What can stakeholders do? Okay, they can create, you can create innovative strategies to help increase that enrollment of those children 0 to 3 and the delivery of services to them. You can establish and test metrics and measures that adequately demonstrate those improvements, and you can help states to reduce the PMPM costs so that more children may be seen with the same amount of dollars in the system. States also reported that they need increased utilization of preventive services across the whole spectrum, across their EPSDT program. The numbers that come in annually are just not sufficient. They also report that they could use an increase in the delivery of preventive dental sealants by all general dentists and pediatric network dental providers. The numbers of dental sealants, the prevalence of sealants are just not high enough, and we all know that the 6-year molar is the most expensive tooth in the mouth. And when the 6-year molar enters the oral cavity and it begins to develop disease, then that's going to become a very costly tooth over the years. So in terms of potential strategies to address this, the states are looking for innovative strategies to incentivize the use of preventive services by enrollees. How can we get more enrollees in to use those dental services, those dental sealants? Okay, they're looking for reliable, feasible, and valid measures and metrics that adequately demonstrate 2 important things. 1, that providers are actually delivering the sealants, and 2, that there's an increase in beneficiary receipt of services. States also report that adults have problems in their state. Now, of course, we know that the adult dental benefit is not mandated in state Medicaid programs, but nonetheless, if the benefit is not delivered in a state, in many instances, those adults end up at the emergency department. So states are looking for ways in which adult dental benefits can be delivered to a broader and an expanding population. They're looking to establish cost-effective provider networks, a better integrated primary dental health care system, and they need to address an aging population with 10,000 baby boomers entering into retirement each year. So what are the strategies? Innovative and reformed adult dental programs states are open. They want to see what kind of innovation folks can bring to the table. They're looking for increased focus on preventive services, expanded use of dental hygienists working at the height of their licensure, dental hygienists working in primary healthcare practices. When a child comes in for a well-child visit, they receive their eye screening, they receive a weight screening, they receive a height screening, an excellent opportunity for hygienists to be able to do an oral health screening at that time and encompass that all within the well-child visit. Dental hygienists also working in assisted living and long-term care facilities. In many states across the country, dental hygienists' scope of practice has been expanded to be able to deliver these kinds of services. But Medicaid programs aren't necessarily enrolling them as or privileging them as clinicians. So that's just an idea of something that states can work toward. What else do states say? States tell us that, again, they need to increase the number of adults receiving preventive services. They need to decrease dental disease incidence in adults. They need to decrease non-traumatic emergency room dental care, and they need to decrease costs associated with adult non-traumatic dental treatment. These items in the left-hand column that you see here are goals. They're goals, they're objectives, they're all items that any Medicaid program could begin to target that would improve their program. And for vendors or providers that work closely with Medicaid agencies, again, these are goals and objectives that you can zero in on. Strategies, again, to impact these particular requests are value-added preventive strategies that target adults, such as annual prophies, exams, and x-rays. Even to just center on preventive services brings that value add to the program. Value-added treatment services such as silver-diamine fluoride to arrest dental disease, dental caries, and the need for ER services. So we know before silver-diamine fluoride was around, we in dentistry understood and recognized that dental caries is a chronic disease, and that when managed as a chronic disease in early childhood, that during that time, the child can age and get older and be able to sit in a chair for further restoration. But with this new silver-diamine fluoride, it arrests disease, and just I believe the literature demonstrates that that 2 applications over the period of a year is most efficacious, and that could really, really save a lot in terms of preventing treatment services and cost of those services. Also, other strategies would include valid, reliable, and feasible metrics and measures that promote and demonstrate improved performance and results. States are also reporting that they need to improve beneficiary outreach. They also want to improve dental service utilization. So, you know, over the years, we've worked hard. States have worked hard. They're contracting now with vendors, and access has always been the target. So what happens when you try to meet all of those strategies that affect access, and yet patients still don't come in and use services? So as these programs are evolving and as these measures and metrics are being developed, we're really targeting ways to which we can, yes, continue to increase access, broaden benefits, broaden networks, if you will, bring in more different kinds of specialty providers, but also more strategies targeted at the population as well. And that really brings us to some of the new strategies that we're hearing more about that would include the social determinants of health. There's lots of discussion right now on how those social determinants of health can really impact these programs. Strategies that really address some of these barriers that we've been talking about, and strategies that improve oral health literacy. States have also reported that they need to implement value-based payment models that focus on quality, not quantity. So many of you have heard value, not volume, quality, not quantity. And that's really important. But how do you address quality? Well, the first thing you have to do is have a standard. You have to know where you're going. And the professional organizations have developed standards. The American Academy of Pediatric Dentistry has phenomenal guidelines and standards for pediatric dentistry and for the receipt of services in their periodicity schedules, et cetera. And I would encourage states and those that work with states to really look at the American Academy of Pediatric Dentistry's guidelines, recommendations, policy statements, et cetera, because they really provide some phenomenal guidance on what constitutes quality. Because it's only when you have that standard or that recommendation or that guidance that you can really measure against. So we would aim to try to meet that. And states have also obviously still reported that integration of systems, okay, that grade medical and dental service delivery. There's been so much discussion over the last, 5 to 10 years about the integration of healthcare services across disciplines. And so the dental schools and the medical schools are working hard to incorporate these principles and these notions into curricula. But they start and stop there. If systems cannot adopt these types of these principles, and if IT, and it isn't just IT, but if systems all the way up, if we have a state agency, for instance, that contracts with a managed care organization that subcontracts with a dental organization, let's not silo all of those systems. Let's make sure that they are talking because there's lots of opportunity there. So potential strategies, again, is alternative reimbursement models for providers, strategies with cost incentives that focus on quality and prevention, electronic dental health records that communicate. Again, that's just one strategy. Mechanisms that link medical and dental records, and then valid metrics, of course, and measures that demonstrate that process, outcomes, and impact have been improved. States have also reported that they need better they need to better manage high costs of dental services. Here again is where value-added programs come in. They're programs that focus on incentivizing the delivery of preventive services, incentivizing fewer specialty referrals, incentivizing and using incentives to reduce the use of the ER, using silver diamine fluoride, as we previously discussed, delivering risk-based care, managing disease, not just quickly restoring it and moving on, but really managing dental caries and other oral diseases as chronic diseases. Managing the population, not just the first few that come in, and actually embedding and implementing case management services that are integrated between dental and medical systems. And then, of course, increasing the adoption of strategies by the provider network. One of the topics that we hear about all the time is program integrity. And states need to uphold the integrity of their programs. And when we talk about program integrity, we talk about fraud, waste, and abuse. It's a topic that nobody likes to talk about, but we all have to talk about it. And states need to constantly be assessing their programs and include efforts that aim to reduce fraud, waste, and abuse. So what are they looking for? They're looking for vendors that can assure that the program, integrity is maintained. They need to enhance program integrity capacity and their functionalities. They need early identification of problems, okay? And they need assurance that when a problem is identified, that it has been resolved. So at the end of the day, there's all kinds of ways in which supporters of Medicaid programs that are fee-for-service and work independently of vendors, can begin to improve or increase the value of their programs. I hope that the suggestions and the ideas that I've shared with you today have given you some level of insight for moving forward. Thank you.
Okay, thank you, Mary, for a great presentation. We appreciate it. So like I said, we're going to have a quick opportunity for some questions, and I do see that that one has come in for Mary, so I'm just going to read it right off the audience chat here. And so it says, Colorado has the advantage of the virtual dental home, or the Smiles Dental Project, which is showing great promise in serving both adults and children. The expanded scope for RDHs, registered dental hygienists, is helping to keep people healthy. A quick shout out to Rep. Singer and colleagues. And we also use the NNOHA dashboard to measure quality and outcomes. NNOHA, by the way, is headquartered in Colorado. Are there opportunities to build on our on-the-ground knowledge that is showing improved outcomes and reduced costs?
So sure, I'll speak first, and if either of the representatives want to respond, there's always opportunity. And I know that in Colorado there are contract vendors, and when new contracts emerge, or when the opportunity for new contracts emerge, that's a phenomenal platform for testing new ideas. You know, it used to be that everything that we did in medicine and dentistry had to be evidence-based. The problem with that is that we had to wait 20 years for the evidence to show up before we could implement it. In this new environment, the culture is to not wait necessarily for all of the evidence to be so solid. There's this whole environment of improvement where we can begin to test new ideas and to test innovations. And I think that the notion, or the collaboration with contract vendors to help states administer their programs provides a phenomenal platform for testing new kinds of innovation.
Great, thank you for that answer, Mary, and thank you for the question from the audience. I do see that we have a few more questions, but we're going to hold those now. We will have another opportunity for Q&A at the end, so we have marked those and can circle back to them later. So at this time, we're going to move into the legislative respondent portion of the webinar. And I will begin that by introducing Representative Jonathan Singer from Colorado. Representative Singer introduced House Bill 1045, and he will give you all the details on that. Representative Singer has served in the Colorado Legislature since 2012, and he is a former social worker and has introduced many bills related to health policy. I will now hand it over to Representative Singer.
Well, thanks for having me, and thank you very much for doing this as well. You know, just to give you a little idea of the political landscape in Colorado, absent of what happened in the most recent election, for the last 4 years, we've had a majority Democratic House and a majority Republican Senate. And so for any legislation to pass, it had to be bipartisan, which really, you know, it fits the mold of what NCSL's mission really is, which is seeking to be a nonpartisan entity that's focused on policy. So what we discovered in Colorado is that the law was unclear as to whether or not hygienists could apply silver diamine fluoride, SDF, to their patients. And the good news is, you know, we're always, well, the bad news is we're always worried about these turf battles that happen between professions, right? Dentists and hygienists, doctors and nurse practitioners. We like to see, you know, just like Democrats and Republicans getting along, we like to see our medical professions getting along as well. And so we were very fortunate that the Dental Association and the Dental Hygienists Association came together on this to say, you know what, let's make this just a bright line clarification in state law to say that our hygienists can apply SDF as long as they have some sort of collaborative agreement with a dentist. As long as there's some sort of understanding, whether it's through indirect or direct supervision, that we would extend this ability to hygienists. Now, there's a lot of things that seem pretty obvious to me, but I'll just share with you. We know that seeing a dentist as opposed to seeing a hygienist is typically more time-consuming. Seeing a dentist is typically more costly. And there's some real benefits of SDF that were already mentioned, but I think the one thing that I like to highlight is the financial benefit. It costs between $20, $25, maybe $30 for a single application to a single tooth, much cheaper than doing a filling or most other kinds of dental work. The other exciting part of this is the opportunity to be able to use this for our underserved populations that may not have access to a dental office, because this is something that can be applied topically. You can do this at non-traditional settings like schools, nursing homes, community centers. So as we're not only talking about doing what's best for our kids to save some of those downstream costs and do the right thing, there's also the opportunity to go into nursing homes with our aging population and do this as well. The other issue that I think really helped drive this home here in Colorado was the fact that this is largely non-invasive. And so when you're dealing with either kids or elders or people who already have maybe some traditional anxieties about seeing a dental professional, this is something that is relatively painless. It's a topical application, and it's something that actually a lot of pediatric dentists have said, this actually helps me build trust with my pediatric patients. I can visit kids. The parents of kids oftentimes are more anxious than the adults, or the adults are more anxious than their kids. But when they see this application and they see it's virtually painless, they're more likely to come back to me and build that trust, and so they're more willing to continue to come see me and continue to care for their own dental health. So at the end of the day, this was a bill that passed unanimously out of a Democratic House and unanimously out of a Republican Senate, was signed by the governor. And it was in large part due to a lot of work behind the scenes by what are oftentimes seen as opposing groups that came together, and then typically pretty moderate groups that are looking out for what's best for kids, and also looking for cost savings in not only Medicaid state coffers, but cost savings across the board in our healthcare system. So that's the short version of it. I did send a brief fact sheet, a one-pager to Eric's that is available for distribution, so you can get a sense of what the top line issues are, and if we have other lawmakers on the line. I know they always like a good, quick take-home version of the game, so to speak. And the last thing that I'll mention about this is the caliber of people we had to come testify in the House and Senate committees was such that it engaged a group of lawmakers who are pretty jaded, but to see the caliber and excitement and the interactivity of the people who came to testify, the pediatric hygienists, the pediatric dentists, who brought hand puppets to show what this looked like, and really made something that could be a pretty dry issue into something that was engaging and exciting, because it actually is all of those things. So I will leave it at that, and I'm happy to hand it off to my colleague, and I look forward to seeing what questions arise.
Okay, thank you, Representative Singer. We appreciate that. It's great to hear that kind of state-specific context and how these issues are negotiated, or at least in your state. And again, for the audience, that resource that the representative referenced is in your resource tabs and available for your viewing. And with that, we will move on, and I will introduce Representative Steve Ellison from the Utah House of Representatives. Representative Ellison has served in the Utah Legislature since 2011. He was formerly the financial manager for the University of Utah Hospital and Clinics, and has authored numerous bills on healthcare policy. Rep. Ellison's legislation, House Bill 435, was enacted this year, and I will turn it over to him now to describe his bill. The floor is yours, Representative Ellison.
Thank you, Eric. If you look at things we've just been talking about in terms of value-based purchasing and state goals, the bill that I sponsored, HB 435, really meets many of those objectives. It was a very creative bill that I cannot take credit for other than simply sponsoring. The idea was brought to me by Dr. Glenn Hansen, who I think is also on the line. Are you there, Glenn?
Yes, I am.
Okay. Glenn is a professor of dentistry and former head of the National Institute of Drug Abuse, very well respected, published academic and clinician. And the basic part of this bill is, just as a way of background, Utah was not a Medicaid expansion state. We just had a ballot proposition that will be expanding Medicaid. But we did have what we called a targeted adult Medicaid expansion a couple of years ago that was aimed at individuals that were chronically homeless, justice involved, or certain other individuals needing treatment that had been released from our state hospital or were living in a homeless shelter. And that treatment also included residential, inpatient and residential treatment for a substance use disorder. Well, the University of Utah School of Dentistry several years ago received a $1.5 million grant from HRSA, the Health Resources Services Administration, to demonstrate that comprehensive oral health care by specially trained dental students and faculty could dramatically improve the positive outcomes for substance use disorder treatment. So over a 3-year period, they targeted individuals that needed significant dental work that were in the middle of a substance use disorder program. And the results were just outstanding. I would think most people participating in this found it very surprising, the multitude of benefits that came out of this program. So what my bill did is their grant ended, but what this bill does is it expanded Medicaid dental benefits to this same population. It wasn't just the individuals that were homeless, but all of these other individuals that had, justice involved incidences and other criteria. So what they found from the 3-year pilot program is they had a sample of individuals that were in substance use disorder treatment and those that were in this FLOSS program where they received, in addition to their substance use disorder treatment, received comprehensive and restorative dental care. And actually the people in the FLOSS program even had a higher rate of addiction to heroin and opioids. What they found, though, is that for individuals in the program, their length of stay in treatment was 282 days versus 129 days for those who weren't in the program, over 100% increase. The number of individuals completing the treatment, those that weren't in this special dental program, 44% completed treatment. Of those in the program, 65% completed treatment, a 48% improvement. Improvement in employment at discharge from the program, it was over 200% greater chance that the individual would be employed at the time of the discharge if they were involved in this dental program. A decrease in homelessness, 55% greater reduction in reducing homelessness amongst this population, and then involvement in drug abstinence was 127% greater improvement than those that were not in the program. So the basics of the bill of HB 435 required our state to apply for an 1115 waiver that we could expand comprehensive Medicaid dental benefits to individuals in treatment. And the bill was so widely accepted that it passed every committee and both the House and the Senate unanimously bipartisan by every step of the way except for one no vote in the Senate on the final vote. There's always one, right? Anyway, and the bill was first introduced on February 21st of this year, and it passed on March 8th. So about 2 weeks from start to finish, which for me is a record, and was signed the following week by our governor. The 1115 waiver has been submitted to CMS. We've gotten a good word from them that it will be approved. As you all may know, if you're waiting on waivers in your state, those were delayed pending the election. We hope to have approval next month from CMS to put this into effect. One last very unique component of this that I think could be replicated in other states is that the University of Utah School of Dentistry, which is our only state-approved supported school of dentistry, said we will pay the state's FMAP share, the state shares portion of the Medicaid match, if the state will create this program and have them come to us or one of our statewide affiliates for treatment. So the fiscal note for this bill was zero. It had the benefit of helping these individuals receive the comprehensive oral health care that they were so desperately in need of, but we had huge other benefits from our pilot population of helping them complete their substance use disorder program, staying in treatment longer, staying employed, and remaining substance-free post-completion of the program. So it really hit a multitude of policy issues in a very creative financial way. One last benefit is that the dental students had an opportunity to work with what is, traditionally an underserved and, often very difficult to serve population. So in their training, they were exposed to these individuals and some of their unique dental needs. And when these students graduate and move out into the field of dentistry, we hope that with this training, they'll be more likely to be willing to treat individuals in the midst of a substance use disorder and hopefully apply some of the same principles that they've incorporated to this program to help those individuals achieve the other benefits. So that's pretty much the summary of HB 435.
Okay, thank you, Representative Ellison. That was a great description. Thank you for sharing that with us. All right. And I did before I move to the next slide, actually, I did want to address the most recent question in the chat box. Where can we find the data for the FLOSS program? Rep. Ellison and I can touch base maybe offline and provide that data to the group, to all the attendees for today's webinar.
Eric, there is a one-pager that I can send you that feel free to distribute with the group that goes over the basics of the program as well as the results from our pilot program.
Excellent. Thank you, Representative. Yes, I'd be happy to share that with the group. Great. Okay, so with the remaining time that we have left, I'd like to open the floor to any questions from the chat box. I'll keep them coming in by all means, and I'll read them out as they come in, but we have received a few, so I'm going to read it off and just pose it to our presenters. I believe it was I believe the question was meant for Mary, but so I'll give her kind of first crack at this. But representatives, please feel free to chime in. The question is: do you see value in the creation of a state dental director role and the creating of a statewide dental plan to help achieve your goals?
So it's interesting, the word state dental director. So there's two different kinds of state dental directors. One would be a state dental director for the Office of Oral Health at the Department of Public Health. I'm not sure what the agency is called actually in Colorado, but in most states, those positions are separate. The Medicaid agency, governs Medicaid and that whole program, and the public health program in the state has an Office of Oral Health. They are very distinct and separate roles. One deals with population-based preventive services, assessment, health status, those kinds of things, education. The other is what we're talking about today is the Medicaid program. So I see I think it's very important for both agencies, both the public health agency in every state and the Medicaid agency in every state to have a state dental director in that position. Now, that said, I think that it's helpful sometimes when that person is one and the same, and I'll tell you why. In years past, dental public health programs were really in isolation of Medicaid dental programs, and I think because the environment has changed so much, and because dollars are few and far between, it's become really imperative that these two agencies and that these two positions really work more collaboratively together. We have and need public health programs to identify individuals that fall through the cracks of the delivery system, which in this case would be of the Medicaid system. So if those public health programs are in place, then we identify people that have fallen through those cracks, we get them the care that they need, but in those public health programs, they should also focus to get them back into the delivery system. And it's in the delivery system where we can better assure that there is routine, continuous care, both preventive and well care, as well as, treatment of disease and that kind of thing. So I think that both positions are very important. Hope that helps.
Great, thank you for that response, Mary. And just to kind of build off that a little bit and turn it back to our representatives, Rep. Singer and Ellison, have you all worked with the state dental director in your state, or is there a state dental director, and how you've experienced that office?
This is Representative Ellison. This might be an indictment, but to my knowledge, we don't have a state dental director.
And this is Rep. Ellison. Were you? I didn't want to interrupt you there. So.
No, to my knowledge, we don't have a dental director.
And actually, I was just going to chime in. I'm not sure we do either in Colorado. I think we might get some better answers from some other folks on that issue, where we tend to be a low administrative overhead state and don't like creating a whole new slew of positions. But I'm looking it up right now, actually.
Great, and thank you for those responses, representatives. And we certainly understand there could be 50 different answers to this question, so we appreciate you all jumping in. I do see another question here in the chat box, and it reads, any suggestions for bringing the State Department of Health director and the Medicaid dental director into a collaborative relationship? I'll pose that to all three of our speakers.
So this is Mary. I think it's very important for the reasons that I just said, that both of those agencies and both of those persons, if you will, or both of those departments work closely together. Like I said, because dollars are becoming fewer and fewer, and because the need for services among low income and different populations are increasing, then I think it's really imperative that programming really be very collaborative.
And this is Representative Singer. I totally agree with that. There's not much to disagree with. I think really there's probably 50 different answers for 50 different states. It really depends on the degree of effectiveness and functionality of your departments. But at the very least, the more that there's a nexus in terms of a conversation, that's almost always a good thing. I think that the question is, a lot of times is who are the people in those places, and how well do they play in the same sandbox together?
This is Representative Ellison. Of course, I'll just concur with what has been said, but I would also say don't overlook collaboration with your School of Dentistry if you happen to have one in your state. The predecessor to the bill I discussed restored Medicaid dental benefits to the disabled that had been withdrawn during the recession. And it was the same arrangement where the School of Dentistry said, we will offer the care to these individuals and through the School of Dentistry and our network of care at no cost to the state because they were paying the state's Medicaid match. And we had a bill just about a month ago that passed committee that will restore Medicaid dental benefits to the elderly, to the aged, under the same funding formula where there's zero cost to the state because the School of Dentistry pays the state match, which is, again, beneficial to the students and to the Medicaid beneficiaries.
Great. Thank you to our speakers for those great responses. And I just wanted to chime in here, and we got some, looks like some folks were doing some research offline, and it appears that Colorado does have a dental director, and that they are located in CDPHE, which is the Colorado Department of Public Health and Environment, which is and not at the Healthcare and Policy Financing Department, or HCPUF. So thank you for those researchers for being on the spot here. Thank you. And we do have another question I saw came in the box. How can legislators evaluate or determine the cost effectiveness of current oral health programs in your state?
Well, I'll chime in real quickly here. This is Representative Ellison. As it relates to the bill I discussed, in some respects, it's very easy to evaluate the cost effectiveness, at least from the state budget's perspective, because there was no cost. I imagine we'll be looking closely at the outcome results of this population when they begin to be treated, just like we did with our pilot program, but tracking their rates of employment, homelessness, and abstinence from drugs post-treatment. Those will definitely be important metrics that we'll want to look at.
This is Mary.
Yeah.
Sorry.
Go ahead, Mary.
Well, I was just going to say, again, depending upon whether you're talking about the public health dental programs or if you're talking about the Medicaid dental programs. If you're talking about the Medicaid dental programs, then again, the measures that we have right now are use of services measures, utilization measures, and those would be the measures of that each state has to submit each year, the 416 data. So they look at the percentage of children that have received any preventive service, the percentage of children that have received a dental sealant. Those are measures that we have now. Are they the best measures out there? No, but they are what we have, and they are a mechanism to be able to measure the effectiveness of a program. If only 50% of enrollees are receiving services, that tells us something.
And this is Representative Singer out in Colorado. I think there's a couple ways to implement measures. One of the frustrating things about the fiscal note process in Colorado is it really just talks about the immediate costs incurred to the state, not necessarily what some of the downstream savings might be. That being said, inside the current governor's office, who will be term limited at the end of the year, he actually has an office that actually looks at a lean process and evaluations. The other thing I would point people to is the Pew Trusts are working on a pilot program to create health notes and take a look at sort of the broader health perspective in terms of legislation, program, and policies. So I think there are ways to measure this, but they may not be through the traditional modalities that we have, with the exception of what our federal reporting requirements currently are.
Okay, well, again, yeah, thank you for those responses from the speakers, and I'm going to start wrapping up the webinar at this point. And before I do that, I just wanted to click back here to our resources slide, which I believe I skipped over on accident at the beginning. So we just wanted to point these resources out. They will be they're NCSL resources, and they can hopefully answer some more questions on oral health policy on the state level, and we certainly encourage you to take a look at those. So with that, I would like to thank our presenters again for sharing their time and expertise on today's webinar. We really appreciate it. And a big thank you to the Oral Health Progress and Equity Network for supporting and assisting with the production of this webinar. My contact information is on the current slide, as well as the information of Program Director Tara Johnson. Please do not hesitate to reach out to myself with any questions or comments. And one more note, in the next week or so, we will have a recording, and slides will be available within the week as well. So thank you all for your participation, and have a great weekend.